Thank you, Danvik and Mark, and thanks to the organizers for inviting me to present today. I'm going to talk about quality improvement to reduce stigma and discrimination in healthcare settings, focusing on structural changes and improvement tools in service delivery. First, just disclosures is that the QISD network has been supported by PEPFAR and ViiV and is currently supported by Gilead Sciences. The network is a partnership, and I wanted to acknowledge the partners who co-facilitate, particularly UNAIDS and APN+, and some specific individuals, including those mentioned on this slide, who have been really instrumental in helping facilitate and plan meetings. So I'm going to talk a little bit about the introduction of the network, its rationale. I'm going to show you a brief video rather than talk at you about the network and what it does and how it's set up, and then give you some examples at different levels of the healthcare system that focus on quality as a strategy to reduce stigma and discrimination in healthcare settings. I'm going to wrap up with a little digression into the key population-led health services model, and then wrap up. So why do we do what we do? We know that stigma in healthcare settings, especially in public health facilities, continues to be a significant problem. Stigma and discrimination have profound impact on health-related quality of life, and there are interventions that are known to work but not routinely implemented, and so we need to close that no-do gap. Routine measurement to identify areas for improvement and interventions in healthcare facilities requires ongoing reinforcement and vigilance. Structural interventions at the organizational level will enable continued focus on measurement and improvement, and interactions between ministries of health, the community, and academia focusing on stigma don't happen routinely, and this impedes dissemination of knowledge, and the network is an opportunity to allow that to happen. And now more than ever, this is important. The changed funding landscape has cut resources for prevention, key populations, and stigma reduction. So opportunities to acquire new knowledge about reducing stigma, learn about best practices, and spark friendly competition are diminishing. Dissemination of information across countries and among stakeholders must accelerate. So why is quality improvement a tool or a strategy to reduce stigma? So first of all, stigma is a social process and it requires systemic actions. And so we need to focus on the systems of care and not just individuals and their behaviors. The drivers of stigma are common, but their manifestations are contextual, and so we need to adapt what we know works to the individual setting in which we are providing services. The process of sustainability and scale-up are inherently dynamic, and we need a structured way to learn as we go, and quality management and quality improvement offer that. HIV programs are already implementing quality improvement, and we need to harness that existing capacity to focus on stigma reduction while layering on this new capacity. And then finally, quality is co-produced, and we need to promote partnerships among communities, providers, and governments to focus on quality in the work that we do. So one of the frameworks that we use was developed by Laura Nyblade, who's probably the foremost researcher on stigma in healthcare facilities in the HIV space. And Laura identified 4 immediately actionable drivers that we can address through quality improvement. One being fear of transmission, another being awareness of stigma, another being attitudes, and then finally the institutional environment in which we deliver care. Because all of these can result in stigma in many different ways, whether it's experienced, whether it's anticipated, whether it reinforces internalized or self-stigma. And those, of course, affect clinical outcomes and then the ultimate outcomes of reaching our targets in health-related quality of life. So in order to tell you how the network functions, I'm delighted to show you a video that was recently produced by a communications intern at UNAIDS in the Asia Pacific office. And so they will get that up for you now.
We've been working on HIV-related stigma for decades. There are many proven interventions to reduce stigma in healthcare settings, but they are often not put into practice. We often know what works, but we don't always know how to make it work. That's where the QISD model comes in. QISD stands for Quality Improvement for Stigma and Discrimination. We bring together multiple sources to understand what's really happening on the ground. One of our most important tools is a standardized survey for healthcare workers. For example, the survey asks, do you worry about getting HIV when drawing blood from a person living with HIV? When many staff members say yes, it suggests fear or misinformation, and shows where more support, training, or clear guidance is needed. We also gather feedback from people living with HIV. Their voices show us how stigma actually feels, and whether our efforts are making clinics safer and more respectful. Once we see the data, we dig deeper. We look for what's causing the stigma and choose solutions that fit the local context. Some clinics focus on training. Others update forms, signage, or feedback systems. Then we measure again. Are staff attitudes improving? Are patients feeling more respected? Are more people coming back for care? This shows us what's working and where we still need to improve. Finally, teams exchange ideas, successes, and lessons. Throughout all of this, community-led monitoring keeps us accountable, making sure people stay at the center. That's how we close the know-do gap and move from knowing to doing better. Together, we turn knowledge into action, amplify community voices, and move closer to a world free of stigma and free of AIDS. The QISD network offers an important opportunity to share knowledge and proven strategies for reducing stigma in healthcare. It brings together ministries of health, communities, and researchers, so we can put what works into practice, faster and at scale.
I really have to credit Meng-Fei Lee, the intern who put this together. I think she did a really nice job. So what I'm going to turn, and so then the other thing is that the way the network got started is that we were funded with the caveat that we could only provide support at the country level and at the multi-country level, and that's how the network got started. And then each country had to take on the implementation of the methodology on their own. And so what I'm going to show you now are some examples of that. It's going to be quick in the interest of time, but it will give you a flavor of how different countries and different facilities have moved forward and the tools that they use. And Thailand is just incredible in terms of what it has done. As part of their National 3x4 plan, they've included a major focus on stigma and actually included the stigma QI, the QISD model, as part of their national plan, and so they have been in the process of scaling that up. And you can see here that this is the model that they're using with collecting data, acting on the data, having policies to support the activities, and providing coaching through the National Ministry of Health. Malaysia has also undertaken a number of activities at the national level, including guidelines for coaching, sharing, developing and collecting the best practices from the facilities, getting together when they did some redesign and brought stakeholders together, so it's been a true partnership between the community and the providers, and then had forums for sharing best practices and continuous coaching with recognition of the best performers at national conferences, and that's national quality conferences. Vietnam has also undertaken a number of activities at the national level. You can see some of the educational materials here, but I want to call out that last box in Vietnamese, which are it's actually what's called a decision or formal guidelines for reducing HIV-related stigma and discrimination in healthcare settings, and this was, adopted formally by the government. In the Philippines, there's a network underway focusing on QISD that involves 15 facilities, and that's being facilitated by an academic partner and being considered for scale-up now by the National Department of Health. Cambodia has standardized their process for getting patient feedback. They call it the PSF. And with support from NCHADS and the ministry, they make sure that there are meetings convened at the provincial level with communities and providers to look at the data from the patient feedback forms and then address their improvement work based on those data. And this has been a long process to develop, but it's now been fully implemented, and it's pretty impressive. Here's some of the data that they've generated, and what you can see here is that although there are some improvements, there is still a great need to focus on stigma. And so I think as we hear people talking about not funding this work, we need to use data to demonstrate why it is so critical. At the subnational level, I could really have devoted this entire talk to focus on the work that's being done in Korat in Thailand. There they have undertaken a comprehensive program across governmental sectors to develop policies and then promote standardized training, and you'll be hearing about the training and the e-learning module from Dr. Achara in the next part of this session, where that training is now being implemented across all the hospitals. There is sharing of the best practices. Community is involved in the process together with the hospital leaders. There's coaching and mentorship from people in the provincial health office and from one hospital to another, and they've been so successful that they're actually going to be providing TA to other provinces in the country. And the QI piece, which is not labeled in this cartoon, is actually embedded in that little bubble where it says measurement and then adapting and continuous improvement based on the data. And then again, they've embedded the methods into their health facility policies. And this really, we discovered this as part of a consultation done at the end of last year, promoted by UNAIDS and the Ministry of Public Health. And I think what became very clear is that this concept of a whole province approach to stigma reduction is the way forward, and one that will create sustainability, especially in a country that is decentralized in the way that it delivers its services. And then there's coaching and support from the national program in partnership with the provincial Ministry of Health. I'm going to quickly show you some facility examples, mainly to just show you how specific QI tools are used. Again, we don't have time to go into the details, but this is an example from the Philippines in Bataan, where they use root cause analysis and the 5 Whys methodology to pinpoint what the system-level root cause of an issue is, instead of just going for a quick fix that may not work at all. So this has been a successful approach across the Philippines. Thailand uses driver diagrams, and I think I happen to like driver diagrams a lot because they help you look at the logic of a problem and its outcomes. And this is an example where in Kukan Hospital they identified inappropriate service behavior and communication and developed a number of interventions, which you can see in the second to right column. But what I love about what Thailand did with this is they translated it into a management plan and assigned responsibility across the whole institution. And this is, again, part of what we call the total facility approach to reducing stigma. And by the same token, in Chengdao Hospital in Chiang Mai Province, they actually addressed self-stigma. And I wanted to show this because very often in healthcare facilities, we say, well, we can't do anything about internalized stigma or self-stigma, and that's not true. And I think you can see here that they went ahead and implemented some interventions that included working in the community, supporting people and their families, and training community health workers to help desensitize people and reduce stigma for people with HIV and key populations. We include a focus on health literacy because we know that literacy improves self-efficacy, and self-efficacy helps reduce internalized stigma. And so this famous PDSA model was used to scale up improving health literacy in Binh Duong province in Vietnam. And again, I'm not going to go through the details of the QI project. You have the slides so you can look at this, but they sequentially worked through interventions and added onto them until they were able to see better results across their entire clinic to improve health literacy. And this was just an issue of people understanding their viral load test results. Over the past several years, we've been able to collect at least 27 interventions to reduce stigma in healthcare facilities, and they are categorized in this change package according to domains of health systems and the chronic care model, and they are also included in a publication which is footnoted on the slide. Okay, so lastly, I want to talk about key population-led health services. I think we know that this is the ultimate structural intervention to reduce stigma by having services provided by people for people. We can't do this necessarily in every single community, but we know that this model has been extremely successful. Recently, in partnership with IHRI, thanks to a very small business development grant from UCSF, we did an assessment of 8 key population-led health services in Southeast Asia. And in these 8 clinics, we actually learned that there were over 80,000 patients being taken care of. So I think the impact of this model across the region is quite remarkable. That'll show up in the next slide. But this assessment consisted of a customized program assessment that was description of services, the standardized quality management organizational assessment that we use as part of our health qual work over the years, and the Washington University of St. Louis Program Sustainability Assessment Tool. The idea was we are intending to identify issues that we could address in a separate network of key population-led health services, which remains unfunded. So as I mentioned, there are over 81,000 patients seen across these 8 clinics. There are over 15,000 receiving treatment and over 65,000 receiving testing and prevention services. There are services for all key populations, and the breakdown is on the table. I won't read the numbers to you. And they offer testing, treatment, PrEP, viral load monitoring, gender-affirming care, mental health, harm reduction services, and so forth, and including one clinic that has already integrated care for non-communicable diseases. All of the clinics receive international donor support, and 6 are funded through national insurance or government funding schemes. And all clinics report data, yet only one had a formal quality management program with considerable variation in the domains of functional QI committees, quality management plans, and routine data used to drive improvement. Most clinics were in the early stages of sustainability planning, reflecting the need for emphasis on long-term program continuity, especially given the disruptions in foreign aid. So I just wanted to call that out because I think this is a model that's been very successful. It needs to be sustained, and we need to advocate for it. And also just to shout out to Lighthouse in Vietnam. I don't know if Tung is here, but they have been providing technical assistance in the community QI model in Laos. And again, it's a way in which knowledge can be spread across the region. So action is possible at every level. We can measure. We can make stigma reduction part of all HIV programs. We can make it an explicit component of delivering high-quality, person-centered services. It can be part of routine QI processes. It can be part of medical training. It can be part of licensure and accreditation. It can be part of supportive supervision and performance assessment, and programs to address complaints and redress systems. I want to let you know to stay tuned for work that is being done at UNSW in Sydney. Carla Trelower, who's done some incredible work there, has been working as part of a large project to create a stigma-free standard and implement it in a network of hospitals there. In July, stay tuned, there'll be launching of a global community of practice from UNSW to expand knowledge and exchange and diffuse innovations. They will be convening their second Tackling Stigma conference in Sydney as well, and I had the privilege of attending the last one, and it was really quite amazing to see 2 full days devoted to stigma across the health system. There's a lot going on, a lot of great research going on, and we have a lot to learn and share. And then lastly, they put on a short course called Combating Stigma. Unfortunately, it's not free, but there are reductions in fees for people from low-income countries if you want to check that out, and the links will be in the slide. So, in conclusion, I want to share with you what I think is an 8-point roadmap for applying quality improvement to stigma and discrimination. We have come a long way, but we have much more of the road to travel. We know that routine application of QI to reduce stigma and discrimination is feasible, but it requires leadership commitment. We see integration of data from both patients and healthcare workers into routine QI activities to inform system-level changes, but we need to see it adapted to current QI processes. We know that HIV-related stigma discrimination is actionable in healthcare facilities through organizational and system-level changes and can show reductions in experienced stigma. I've shown you the changes that we've captured so far, but we need to focus on documentation and dissemination as we go forward. Ongoing disaggregation of clinical performance data by key populations is essential to show potential disparities in care. However, sexual and behavioral health history taking remains underperformed in public health facilities, and it is of questionable quality. Activities to assess patient experience, focus on treatment literacy, and involve community through common indicators are integral parts of reducing stigma and discrimination, and they can be consolidated within measurement platforms that also include health-related quality of life. Key population health services are a unique component of the health system service continuum offering stigma-free care, but they require ongoing support. Sustainability of stigma reduction activities in healthcare facilities requires integration with national policy and subnational implementation of program in tandem with facility leadership and planning. The whole province approach is a promising model to combat stigma. And finally, vigilance is important at all levels of the health system if we're going to continuously address stigma in healthcare settings. This is from our last network meeting, and I want to thank you for your time and attention. Yeah.